Come to part 2. We just have a few more pulses left now. Now, digoxin, which is a positive inotropic drug, is going to cause something known as a VPC, a ventricular premature contraction. So, your first contraction is going to be followed by a premature beat. You will see some sort of a fusion here, giving us the bigeminy. This affects the strength of the pulse waveform, which may be more in this case. And since there is a premature contraction, it will be followed by a longer compensatory pause before the next contraction. In digoxin toxicity, then we have pulses alternans, like the name suggests, we have alternating high volume and low volume pulse. This happens in left ventricular failure because in LVF, the ventricle is not able to push out blood, so the stroke volume is decreased. That leaves more blood inside for the next cycle, which increases the end diastolic volume. Therefore, the next stroke volume is going to be high. So, therefore, we'll have the high stroke volume, low stroke volume. Now, understand this concept for the next pulse. When we breathe in air during inspiration, the negative intrathoracic pressure increases. That pulls all the blood into the pulmonary circulation. So, there is a pooling of blood in the pulmonary circulation, in the pulmonary venous capillaries or in the capillaries. So, that in turn decreases the venous return from the pulmonary veins into the heart. As a result, the left ventricle receives less blood. So, we have less end diastolic volume, we'll have less stroke volume, and as a result, the systolic PP will reduce. Now, this drop in SPP is a normal phenomenon, but only when it is less than 10 mm. But if this normal phenomenon is exaggerated up to a point where the SPP drops more than 10 mm of mercury, then that is called pulsus paradoxus. The drop in SVP is going to be more than 10 mm because the venous return to the left side of the heart is less, which could happen when there is a restrictive filling of the left ventricle, for example, in constrictive pericarditis and cardiac tamponade. Or it could be because of excessive pooling in the pulmonary circulation, which is seen in cases of COPD and massive pulmonary embolism. How do you demonstrate pulsus paradoxus? Imagine this is a person's arm. You put on a BP cuff and inflate it all the way up to the systolic blood pressure, which is the point you had stopped hearing all the Korotkov sounds. And then if you lower the BP, you will start hearing the Korotkov sounds, but you will note that here you are hearing them only during expiration. This lowering of the cuff pressure is going to be very, very slow up till you reach a point where you hear the Korotkov sounds both during inspiration and expiration. That is, you hear continuous Korotkov sounds. Now, this pressure should ideally be less than 10 mm. But like we said, if this fall is more than 10 mm, then we have a pulsus paradoxus. Remember the conditions that you see it in. And we're done with pulse.